Imagine spending, I don't know, like a decade and millions of dollars developing this revolutionary life-saving drug.
Yeah, a massive investment.
Right. And you run tests in a perfectly controlled lab, and you get flawless results.
Mm.
But then, when you finally release that drug out into the real world, it completely fails.
Which happens way more often than people think.
Exactly. And why does it happen? Because you chose the wrong 500 people to test it on. That is the terrifying reality of biomedical research.
It truly is. I mean, choosing your study population isn't just some administrative preliminary step.
No, not at all.
It is the absolute foundation of your work. If you get that selection wrong, your entire study crumbles into this diagnostic muddy water before you've even collected a single data point.
Welcome to the Deep Dive. We are super thrilled you're with us today.
Yes, glad to have you here.
If you are prepping for a medical exam right now or, just trying to genuinely master research methodology, you know firsthand that staring at a towering stack of study notes can feel totally overwhelming.
Oh, absolutely. It's a lot to take in.
So today, our mission is laser-focused. We are tackling Lecture 13 from the basic course in biomedical research, the BCBR.
And the core topic today is the selection of study population.
Right. And we're not just going to, read a textbook at you.
No, nobody wants that. We're going to break down the core multiple choice questions from your source material, and we're going to focus entirely on the underlying logic.
We will explicitly state the question numbers so you can track along with your notes.
Right, but our real goal is to explain the mechanics behind the concepts. We'll give you the correct answers in clear terms, but more importantly, we'll explain the why.
Exactly. Because once you understand the mechanism of how a researcher thinks, no exam question can trip you up. Okay, let's unpack this.
I'm ready.
Before we can worry about data errors or participants dropping out, we have to figure out exactly who we are studying. And to do that, I want you to think about making a massive pot of soup.
A pot of soup. Okay, I like where this is going.
So you're making this giant pot of soup for a banquet, and you need to know if it needs more salt. You don't need to drink the entire pot.
Right, that would be absurd.
Yeah, totally absurd. You don't even need to drink a whole ladle's worth. You really just need one well-stirred spoonful to tell you everything you need to know about the whole batch.
That makes perfect sense.
Research works exactly like this. It's basically a funnel.
That is a brilliant way to visualize it. I mean, the entire pot of soup represents our absolute ideal. It's everyone in the entire world we want our research to apply to.
The ultimate goal.
Exactly. And this directly addresses question 11 in your notes. It asks what the population defined by clinical and demographic characteristics is called.
And the answer there is the target population. Option A, right?
Yes, the target population. It's the big picture.
Right. And if you look at question 2, it reinforces this exact concept by asking what the target population is determined by.
Which we just kind of gave away.
Yeah, we did. The correct answer is D, which is both A and C. That corresponds to demographic characteristics and clinical characteristics.
So to make that concrete, if we are studying a new pediatric asthma inhaler, the clinical characteristic is simply having asthma.
Right.
And the demographic characteristic is being a child.
Notice what is deliberately missing from that definition, though. Location.
Exactly. The target population is purely theoretical. It is every single child with asthma on planet Earth.
But, practically speaking, you cannot test every child on Earth.
No, you definitely don't have the budget for that.
Which brings us to the ladle in our soup analogy. Question 12 asks about this. It says, the population defined by geographical and temporal characteristics is called as what?
And the correct answer here is B, the accessible population.
Because you can only reach the children who live near your specific research hospital.
Right, that's your geographical constraint.
And you can only study the ones who happen to be available during, say, the 6 months you are actively running the trial.
Which is the temporal constraint. Right. So the accessible population is just the people you can actually access in the real world.
And finally, we get down to the spoonful. The actual individuals who end up enrolled in your trial.
The ones actually taking the drug.
Exactly. Question 3 asks if the study sample is a subset of the accessible population. And question 27 asks you to identify the true statement regarding study populations.
So for question 3, the answer is A, true.
Simple enough.
Yeah. And for question 27, the correct answer is A, study sample is a subset of the accessible population.
It's a perfect funnel. You start broad with the target, narrow it down geographically and temporally to the accessible, and from there you get your sample.
Your final, very small study sample.
But let me push back on this for a second. Let's say we have our accessible population, right?
Okay.
So there are 10,000 kids with asthma in our city.
Okay.
Why not just test all 10,000 of them? Why bother pulling out a smaller sample at all?
Well, this raises an incredibly important point, and it really captures the central tension of all scientific research.
How so?
It's perfectly addressed by question 1. It asks, selection of study participants depends on what? The answer is D, all of the above, meaning representativeness, acceptable cost, and adequate size.
Oh, right. We call this the golden triangle of study design.
Exactly, because testing 10,000 people would cost an absolute fortune.
It would take years.
Yeah, time, money, and personnel are strictly finite resources. You might only have the grant money to test 500 children.
So that gives you an acceptable cost and an adequate size for your statistical power.
Right. But the critical third leg of that triangle is representativeness. Going back to your analogy, that spoonful of soup has to be perfectly stirred.
Oh, I see.
Because if your spoon only scooped up the salt that sank to the very bottom of the pot, your conclusion about the whole batch is going to be wildly wrong.
So what does this all mean in practice? Because finding the right people is really only half the battle, right?
Yeah.
You need to know if the data you're getting from them is actually true and useful.
Definitely. And this is where we transition into validity and representativeness.
Let's look at question 4. It asks, representativeness of a study sample refers to what?
The precise answer there is A, the extent to which the characteristics of the sample accurately reflect the characteristics of the population.
So if your target population is highly diverse, but your sample only includes like one specific demographic, you completely lack representativeness.
Exactly. And question 22 ties right into this outcome.
Yeah, it asks representativeness of the study participants similar to following aspects of a research study.
And the answer is A, generalizability of the findings.
Generalizability, that's a big one.
It is. If we connect this to the bigger picture, generalizability is the entire purpose of doing the study in the first place.
Right, because if you test a drug on 500 people, you need to be able to confidently declare that this will work for the millions of people out there.
Exactly, for your whole target population.
Yeah.
If your sample isn't representative, you absolutely cannot generalize.
Medical history is unfortunately full of tragic examples where this went wrong.
Oh, tons of them.
Like, think about early cardiovascular trials that almost exclusively used middle-aged men as the study sample.
Yeah, that's a classic example.
They generalized those findings to women, but heart attacks often present completely differently in women.
Right, the sample wasn't representative, so the generalizations were fatally flawed.
Which brings us to the two distinct types of validity you really need to master for this exam: internal and external.
Very important distinction. Let's look at question 18. It asks, the degree to which the observed findings lead to correct inferences about phenomena of interest in the study sample is what?
And the answer is C, internal validity.
So internal validity is essentially asking, did you do the math right for the people actually in the room?
Did you measure things properly within your specific sample?
Precisely. It is truth within the study. But then question 17 zooms out.
It asks, the external validity in a research study means what?
And the answer is C, the degree to which the inferences drawn from a study can be generalized to a broader population beyond the study population.
So that's the truth in the universe.
Mm.
And question 14 is the practical application of that exact idea.
Right, it says, a researcher found an inference about a particular disease of interest. If he or she wants to generalize the results, it is important to have what?
And the answer is B, external validity.
You can run a perfectly controlled, highly internally valid experiment on a specific group, say elite athletes running on treadmills in a sterile lab.
Sure.
But if you try to apply those metabolism results to the average sedentary office worker, your external validity is zero.
Because the real world is just messy and unpredictable.
It is. And what introduces that messiness? Bias.
Ugh, bias. The enemy of research. Question 28 asks us to evaluate this statement. Biases can affect both internal and external validity.
And the answer is, naturally, A, true.
I mean, if your lab's blood pressure cuffs are all calibrated incorrectly, that is an instrument bias destroying your internal validity, right?
Exactly. And on the flip side, if you only recruit participants from a luxury high-end health club, that is a selection bias destroying external validity.
Right. And, while theory is great, the exam and really your future career will test you on practical scenarios.
Absolutely. You have to know how to apply this.
I love how these concepts start intertwining when you apply them. Let's take them out of the theoretical realm. We need to walk through how to systematically dismantle word problems.
Word problems can be tricky if you don't break them down.
So put yourself in the shoes of the investigator for question 23. You intend to estimate the prevalence of urinary tract infections, or UPIs, among circumcised children under 5 years old in Jaipur City.
Okay, got it.
However, you actually select your participants from just one government hospital. The question asks, which of the following is the target population in this study?
Okay, let's use the funnel we built earlier.
The soup funnel.
Yes, the soup funnel. The target population is the absolute ideal, defined purely by clinical and demographic traits.
So who do we ideally want to know about in this scenario?
The answer is B, all circumcised children aged under 5 years in the city.
But then, question 24 flips the script on us. It asks, which of the following is the accessible population in the above study?
Now we have to apply the real-world constraints. Where did the researcher actually go to get their data?
They went to one specific hospital.
Exactly. So the accessible population is C, all circumcised children aged under 5 years attending the government hospital.
So the target is the entire city's relevant demographic, but the accessible is the tiny fraction they could geographically reach.
Perfect application of the concept.
Here's where it gets really interesting, though, regarding where you choose to recruit. Question 9 asks, if your research question is related to diagnosis, treatment, or prognosis of a severe medical condition, then it is an easy and cost-effective way to recruit the study population from the community. True or false?
And the answer is B, false.
Why is that false?
Well, this is a matter of strategic efficiency. If you are studying a severe condition, let's say advanced heart failure,
Right.
you are not going to find enough data by just knocking on random doors in a suburban neighborhood.
Oh yeah, that would take years.
And it would bankrupt the entire study. You have to go to clinical populations. You go straight to the cardiology wards.
That makes total sense. But conversely, if you are studying something like the common cold, community recruitment makes perfect sense.
Exactly, because it's everywhere.
Which segues perfectly into figuring out exactly who is allowed into your study and who gets shown the door. Inclusion and exclusion criteria.
This is a huge part of study design.
Take a look at question 29. It says, in a community-based vaccine trial, which aims to compare the one-year incidence of intussusception in children receiving or not receiving rotavirus vaccine, which of the following can be a likely exclusion criterion?
Okay, so for a quick bit of medical context here, intussusception is a serious condition where a part of the intestine folds into itself, kind of like a telescope.
Ouch.
Yeah, it's very serious. But the key detail in this specific question is that we are tracking this over a full 1-year period.
So the right answer for an exclusion criterion is A, children who may leave the study area within a month.
Right, because if you know a family is moving out of the state in a month, you are absolutely guaranteed to lose them to follow up.
They just won't be around to give you data for the next 11 months.
Exactly. They have to be excluded on day 1 to protect the integrity of the data over that entire 1-year timeline.
Now, contrast that logistical exclusion with question 30. It asks what cannot be an inclusion criterion for a Zika virus cohort study among pregnant women.
The core principle you need to internalize here is that inclusion criteria must strictly define the clinical and demographic characteristics of the disease state.
So pregnant women with Zika is an inclusion criteria.
Exactly. But logistical conveniences like lives near the clinic or has a smartphone, those should never be inclusion criteria.
Right, because those are administrative factors, not scientific ones.
Exactly. You don't want to define your disease by who owns an iPhone.
Okay, so we've perfectly defined our funnel. We've ensured internal and external validity. We've set strict criteria.
We are doing great.
But here is the terrifying part for any researcher. You are dealing with human beings. And humans are chaotic.
We are very chaotic.
They drop out, they move, they get bored, they change their minds. How do we handle the messy logistics of recruitment and retention?
This is exactly where the textbook meets the pavement.
We have 2 identical questions in the notes, questions 7 and 20. They ask, participants may be excluded from the study because of what?
And the answer for both is D, all of the above.
What are the specific reasons there?
Well, first, interference with the success of study follow-up, like the family moving away that we just discussed.
Right.
Second, ethical concerns. If a participant is highly vulnerable, or if the intervention suddenly poses a unique health risk to them during the trial, ethics demand they be excluded immediately.
You can't just keep hurting them for the sake of data.
Exactly. And third, interference with the quality of data collection.
What does that look like?
Well, if a participant fundamentally cannot comprehend the consent forms, or they aggressively refuse to follow the study protocols, their inclusion will fatally compromise the data.
And participant attrition, people just leaving the study, is a massive threat. Questions 10 and 15 ask, reasons for interference with the success of follow-up in a study may include what?
Again, the answer is D, all of the above.
Humans just keep getting in the way of the science.
It's true. And this isn't just about acknowledging that people move. It's about understanding how that movement destroys your statistical power.
Right.
The options list outmigration from the study area, marriage causing a demographic move, and outright refusals to participate further.
Think about it. If you need 500 people to maintain adequate statistical power to prove your drug works, and 100 people drop out because they got married and moved to a new city, your entire study might suddenly become statistically useless.
Yeah, you've completely lost your adequate size.
Which is why there is one defining factor that trumps almost everything else in study design. Questions 8 and 19 both ask, while choosing the accessible population and the sampling approach for selection of study population, an important factor that we need to consider is what?
And the answer is feasibility. Option C, or A, depending on your test version, but the word to remember is feasibility.
Feasibility is basically the ultimate gatekeeper of science.
It really is. You can draft the most statistically flawless, perfectly representative, globally inclusive protocol in the history of medicine.
A true masterpiece of a study.
Yes. But if it requires tracking 50,000 people across 10 countries for 20 years on a $50,000 budget,
It's never going to happen.
it is simply not feasible. The study will never get off the ground. Practical reality always wins.
So, knowing all these threats, how do researchers actually fight back? How do we keep people engaged in the real world?
Question 5 asks exactly that. Non-response in a study can be minimized by what?
And the answer is D, all of the above.
You basically have to use tactical empathy.
Tactical empathy. I like that.
The options lay out the playbook.
Right.
Repeat contact of the study participants so you don't just give up after one single missed phone call.
Right.
Providing compensation because you are asking for their valuable time, and that should be respected.
Absolutely.
And using bilingual or translated questionnaires to ensure language isn't creating an artificial barrier to entry.
And question 16 builds on that empathy by looking at how you actually design the questionnaire itself. It asks, less invasive and less sensitive questionnaires will do what?
The answer is D, reduce the non-response.
It is basic human psychology.
It really is.
Yeah.
If a researcher hands you a survey asking incredibly intrusive, deeply personal questions right out of the gate, your instinct is to throw it in the trash and walk away.
Yeah, I'm not answering that.
Right. But if the questions are framed gently, respectfully, and clearly, you are much more likely to stay engaged.
But let's be real here. Even with the best tactics, the most polite surveys, and perfect planning, errors will occur.
Oh, inevitably. Typos happen. Equipment glitches.
A participant accidentally lies about their diet because they forgot they ate a donut.
Exactly.
Questions 13 and 21 ask how we protect our study from this inevitable noise. They ask, random errors can be effectively handled by or helps to minimize the random error.
And the answer is your ultimate mathematical shield. Adequate sample size.
What's fascinating here is the mechanism behind that shield. Think of it like flipping a coin.
Okay.
If you flip a coin twice and happen to get two heads, you might falsely conclude that coins always land on heads 100% of the time.
Right. That is a massive random error.
But if you flip that exact same coin 10,000 times, the random streaks of heads and the random streaks of tails will eventually cancel each other out.
And you will arrive at the true 50-50 probability.
That is exactly how an adequate sample size dilutes random error in a clinical trial. The sheer volume of data smooths out the chaotic noise, allowing the true scientific signal to shine through.
That is such a clarifying way to look at it.
Okay, we have officially powered through the core concepts for Lecture 13. We've navigated the funnel from the target population down to the study sample.
We've debated the crucial difference between internal validity in the lab and external validity in the universe.
And we've tackled the harsh realities of feasibility and human unpredictability.
And remember, mastering this material isn't about memorizing 30 arbitrary answers. It's about understanding the underlying architecture of how a study is built.
Once you grasp the why, the exam questions will naturally solve themselves.
Absolutely.
Now, before we sign off, We want to leave you with a provocative thought that takes everything we just discussed and applies it directly to your everyday life.
Think about the apps on your phone.
Yeah. Tech companies and social media algorithms are constantly running massive experiments on all of us.
They A/B test new layouts, tweak algorithms, and measure your engagement minute by minute.
The next time your favorite app updates with a subtle new feature, ask yourself, are you truly their target population?
Or are you just the most feasible, highly accessible sample they could use to harvest data?
It completely changes how you view the digital world.
Yeah.
Suddenly, that funnel isn't just a clinical research concept.
No, it is the reality of how your data is being gathered right now.
Thank you so much for joining us on this deep dive. We are always here whenever you need a conceptual refresher before the big exam. Keep questioning the data around you, and we'll catch you next time.